Give you a recap of what I sense we learned today. Before I do that, I just want to say thank you to Representative Pigman and Representative Jones for hosting this, and for Senator Joyner, all of you guys being a team going forward as we move into this next session. I think it's really important that we use this as a stepping stone into a much more broader, robust conversation about what we're going to do in the area of telehealth and telemedicine. I'm going to put a quiz question out there for you. See if anyone, if you know the answer to this, raise your hand, okay? What do these counties have in common? Okay? Franklin, Calhoun, Jefferson, Madison, Dixie, Gilchrist, Lafayette, Glades, and Hamilton County.
None of them have a hospital.
Very close. One of them does, but the rest of them have less than 10 physicians in the entire county. So let's think about that. We have a chunk of our population with no hospitals or very few physicians. In fact, Hamilton County only has 2 physicians in the entire county. So how do you manage a population and help them with the healthcare needs that they have? As we look at what hospitals are going through today in the transition of reimbursement and in focus on quality and outcomes, where we are being led by our partners at CMS is what? Population health. Population health. How will we get there? How will we get to whatever that utopia of population health will mean for us if we don't have all the tools? We've got to have all the tools, and this is a tool that's been tested. The VA has shown it. They've been doing it for a long time. But you know, the state of Florida has been doing this for decades. We do it with our child protection teams in the Department of Children and Families. Our child protection teams actually use telemedicine to be able to investigate children who have been abused sexually. And that information is done in a very closed and private setting and shared with the physicians who are doing, helping do the examinations. We've been doing that for years. But we can't make this technology available for the rest of us. And I think that's the challenge that we all have to have. Let me go through some of my notes. Pretty much everyone talked about what I was going to talk about. So I'm going to close here with what I think is some of the agreement that we've come up with. Okay, the technology works, correct? I think there's broad agreement that technology works. I think we can say that the benefits are what? Reduced inappropriate admissions, reduced readmissions, reduced ED visits, reduced mortality, reduced ED stay, and increased clinical outcomes, high patient satisfaction, high staff satisfaction that resulted in better management of care. Now, isn't that a great model for us? Isn't that what we're all looking for in trying to use those scarce resources to improve those clinical outcomes and at the same time help us to reduce costs and manage these patients? Now, these are some of the things we talked about today, but there's one piece that we really didn't focus in on too much, and that's in the area of telepsychiatry. We had a meeting last week. Martha DeCastro, one of my colleagues that's here, she hosted our CNOs last week, our chief nursing officers, and we also had our psych council met. And we all had conversations about what we were doing in the area of telehealth. And we hit most of it on the acute care, we hit most of it on primary care, but I want to throw one piece out, and that was in telepsychology, which we didn't talk about. And that was some of the results that we got back from Baycare Health System, which showed that when they deployed telepsychiatry in one of their hospitals, they saw the time in which their patients were seen cut from 24 hours, these are psychiatric patients, from 24 hours to 2 hours. From 24 hours to 2 hours. And anyone who spent time in an emergency department can see that there's a very large population of folks that are in need of behavioral health services. So that's one thing I would throw out to you. And a piece of that which we didn't talk about, which is somewhat delinked from this, but I'm going to link it, and that is how do we do an encounter to determine whether or not the person meets criteria. So Representative Pigman, as emergency room physician, has probably been placed in that responsibility of having to make that determination. But he has to do it, or a psychiatrist has to make that determination. But imagine if we were able to use telehealth or telemedicine to be able to help us in that. Imagine what we could do if we had to have a consult with a circuit judge to be able to do that as well. So we could reduce cost, we could probably speed up the process somewhat. And that's something we didn't touch on, but I wanted to throw that out there. We've had conversations about EICUs. If any of you have a chance to see what they're doing at Health First or what they're doing at Baptist in Miami, to be able to see what they're doing in their ICU, it's phenomenal. Be able to have the backup that you're looking for from the direct caregivers, to have an integrated team that can help you with managing your patients. We can go on for, in fact, that would be a whole field hearing I think we would probably enjoy. And the areas of transition care and of course, managing the care of patients in their home and in their community. And so for those of you who are here in Gator Country, I'm here to tell you, Georgia has a better model than we do, okay? You don't have to look very far to see what the Georgia Coalition on Telehealth has done. And I think it's a model that we can look at, and for that matter, North Carolina as well. Both of them have developed models that have been in place for a while. Well, North Carolina is most recent, but Georgia certainly has been in place for a number of years. And I'm going to just share you a couple points from Georgia, and I'll close, and I think we'll move on to the conclusion of our program. But let me just show you a little bit what Georgia has. Georgia not only has a very robust program, but under Medicaid, it will reimburse for live video when the service is medically necessary. It includes office visits, pharmacological management, psychiatric services, radiology services, and some physician fee services. Georgia requires private payers to cover telemedicine services subject to contract terms and conditions. All of the providers must be licensed in the state of Georgia. And the locations for service delivery include the provider's office, hospitals, rural health clinics, federally qualified health centers, skilled nursing facilities, community mental health centers, Georgia public health clinics, school-based clinics, and critical access hospitals. So I think there's agreement, if we all nodded our head, that this is someplace that we need to be headed, the direction we need to be headed in. And so we as the Florida Hospital Association, we'll be talking about this again on Friday when our advocacy committee meets, are here standing to support our legislative leaders to advance this and move this forward. So again, thank you for the opportunity, and I don't want to keep anyone from their cookies or their 2.5-hour drive home from Martha and I. So thank you very much.
Let's give our panelists a round of applause. And I hope Gary's not going to get upset with me, but we have provided you with a listing of all the legislative activity that's been going on around the country. And that information is available to you in an effort to try to keep us a little closer to our time frame instead of us going through state by state where we are. What we're going to go ahead and do is to close us out so we can actually see our demonstration. And I want you all to know that all of our presentations will be available for you via link that we'll send out to you at a later time so that you have access to all of the presentations. Has it been worth it? Yes. Are you excited about where Florida is and where we have the opportunity to go? At this time, it's my pleasure to introduce to you Dr. Kevin Barrett, and he is going to give us a demonstration of the Mayo Clinic stroke program. Let's give him a round of applause as he comes.
Hi, well, this is the easy part, and this is the fun part. I'm the director of the telestroke program here at Mayo Clinic in Florida, and what I'm going to do briefly is just show you how a typical telemedicine encounter looks from the provider's perspective. So what we're going to do is have a laptop brought in, and maybe, Hope, could I just borrow you? I think Dale is outside with the laptop, and she might be in the office to the left, and she's going to bring it in. We operate a hub and spoke system here at Mayo Clinic in Florida, and what we really are geared to do is to evaluate remotely stroke patients and identify those that might be eligible for the time-sensitive therapy called TPA, which is the only FDA-approved treatment for acute ischemic stroke. And this doesn't happen just in small community or critical access hospitals. There are large hospital systems that don't have 24/7 coverage by their local neurologists. So this is a problem that's being addressed really in two ways. One is through telemedicine, the other is through neurohospitalists. And we operate both models here. But what I'll share with you is we've done over 500 consults at Mayo Clinic in Florida in our network. We have an average response time of 2.6 minutes from when the emergency department physician calls us to when we're on the phone with them getting the preliminary information regarding the patient that they have. We've treated over 80 patients with TPA. We've had a very successful approach to that. And we also see patients not only in the emergency department, but also on the floors of hospitals and in the critical care unit. So let's, I suspect we'll have this laptop brought in here in a moment. But I wouldn't feel compelled. I would go after all that food over there if I was in your position right now, because this will take a minute or two to set up. And I don't know if ASA or our AV people are here. Could I give you a number? 39612 and just 39612 and just ask Dale to bring the laptop. I think she's literally next door. Thanks.
While we're waiting for her to come, Gary, let me have you to go ahead and come up and give us some closing comments and to go briefly through some of the information you were going to share with us on the stage.
Thank you. Well, there are a couple of things while we're waiting I'd like to mention. One is, Florida needs to do what Florida needs to do to deal with its resources, what its needs are, and I'm not going to begin to tell you what those are. But there are a lot of resources to help Florida, a lot of states that are further along the learning curve on this that Florida can use. The other states as resources. The other thing is American Telemedicine Association wants to be a resource to be able to be used. So in addition to some information about legislation, we have a number of state best practices that we have put out publications on and continue to work with you. Doing the parity legislation is very important. But the other thing I would say is you need to be able to then deliver the services. My state of Maryland enacted parity legislation a year ago, and we're really not that much further now than we were then because the providers haven't come together to create the network, to the relationships among facilities and other things that are necessary. So one of the other parts is while the parity legislation is very important to enable what goes on, to think beyond that and how do you actually create that in the state of Florida and to be able to have the state do a task force to pull people together, all of the medical schools, the community health centers, rural health interests to take that legislation, very important, and actually make it a reality for the people of Florida.
Thanks. We're just gonna adjust your volume a bit, okay?
Okay. I'm talking. How does it sound?
You're good.
Talking.
You're good, Mark. All right. All right. Can you guys hear me okay?
Yes.
Okay, good. So what, I'm just going to talk kind of back and forth between you guys, but for the audience, just so you see, this is the interface that we use on our end. The bottom is what the patient is seeing projected onto the screen of the remote telepresence device. So usually the provider's face, and then as you can see here, we're able to kind of pan, zoom, and tilt. And we've got a patient here. We have our physician, Dr. Rubin, and our nurse coordinator, Lisa Mooney. So Dr. Rubin, why don't you just share with me what you have here and give us a brief summary.
Yeah, we have a gentleman who's been having some difficulty with speech and some weakness on the right side of his body for the last hour or so.
Okay. What is his name, Dr. Rubin?
Kevin. His name's Kevin.
Okay, excellent. Kevin, when did this begin?
Afternoon.
Okay. All right. Good. And Dr. Rubin, were you guys able to establish time of onset?
We were able to speak with his friend. He was with a friend when this happened, who told us that in mid-sentence at about 2:30 this afternoon that he started to have difficulty with the speech.
Okay, great. Well, maybe we'll examine Kevin. I just want to show the audience here some of the resolution we can get, and maybe we just start with perhaps the eye movements. And I'll zoom in just so we can get a good look here, and we'll see the horizontal eye movements.
Good, Kevin, do us a favor. Look all the way to the left here. Keep the head still toward the camera. Just follow that finger all the way to the left. Good. Let's go all the way to the other side. All the way to the other side.
Okay.
All the way to the right.
And then Dr. Rubin, maybe you can just put him through some vertical eye movements just so we can see that as well. Okay,
Open the eyes wide. Good.
excellent. Kevin, can you just raise your eyebrows like you're surprised for us? Okay, and close them tightly. Okay, tight as you can. All right, good. And your last name is not Khan, is it? Okay, it's not Kevin Khan. All right, so there's a smile. There's a symmetric smile. Stick out your tongue for me. Okay, excellent. And why don't we do a motor exam, Dr. Rubin? Let's just see how the motor function is. We can start with the left.
Good. Let's bring your left arm up. Hold it up here. Keep it up here for 10 seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Excellent. You can relax this arm. How about this one? You can bring that one up by yourself? Not really? Okay, let me help you here. Keep it up as best you can. Okay? 1, 2, okay, that just goes straight down. How about this leg? Let's keep it here. 1, 2, 3, 4, 5. Perfect.
Good.
Let's try that with the right leg here. You have a good view there?
Yeah, I think we're good.
Okay. Let's bring this one up. Let's keep this here for 5 seconds as best you can. 1, 2, and there's drift down to bed.
Clearly weak. I'm just going to show you a few things on the screen here, Kevin. And why don't you just describe what you see for me here?
Kid.
Difficult to speak.
Dish.
Huh? How about this? Can you name this object for me? How about this?
Tree.
All right, good. All right. So just that's, we've got for stroke, what's nice for telemedicine is that we have a standardized, validated measure of stroke severity that can be relatively rapidly assessed. And it turns out that it's largely an observational examination. So between interviewing the patient regarding orientation and leveraging the skills of either a bedside nurse or a physician, we can really get a reliable measure of baseline stroke severity that can guide future treatment decisions. So this becomes a very effective and the reason that stroke was one of the first problems that telemedicine was applied to and demonstrated utility. So I'll stop there. I just want to thank you guys for joining us here, and we appreciate your help, okay? Bye-bye.
All right.
Okay, but I think that gives you a little bit of a sense at least of what it's like from the provider end, kind of integrating that kind of information. And I'll stop there. I know we're running over.
Thank you so much.
Sure.
I really do want to thank all of you for taking the time to come out today to share with us. This has been a long way coming, a long time coming. And together, I know that we can make it happen. One of the things that I really appreciate is for all of our lobbyists, do like that for me, you guys. I appreciate you guys because I know that you all will help to make this happen with your various organizations and agencies that you represent. Us being able to be around the table together will make sure that Florida has what it needs in order to make sure that we have parity, that we have the opportunity to provide quality, cost-effective health care for all Floridians, regardless as to where they are, and knowing that they will be able to have a successful outcome on the back end. So I want to thank Net Communications for helping me out with this. I want to thank my staff, Valerie and Bobby, for being here today as well. We could not have done this without you guys, and definitely to Mayo Clinic. Now, you wanted to show us something else.
We have an opportunity for anybody who has a few minutes to go ahead and out and see Mayo Clinic's new simulation center, which is the cheapest. And so if anybody has an extra 2 minutes to spend with us, we'll have a group and I'll take you out there. It's in a different building, so I'll walk over there. But if you want to do it, please join us after.
Lane, about how long will that take?
15, 20 minutes.
Okay, so if you have time to see what is to come, you know, you are on a campus that is cutting edge and has been cutting edge for many years, and so the opportunity to see some of the things that they have going on is something that you don't always get an opportunity to do. So if you have the time, please take advantage of it, and once again, please give a hand to my partner in crime here, Representative Pigman. I want to again thank Senator Joyner for being here and staying with us throughout this. And earlier I missed thanking Representative Powell, who's online and watching us via live stream. And also please give Representative Cummings, who's still here with us, another hand. Thank you all so much and have a great afternoon.
Sorry. I know. No, that's not a problem. Sorry. There we go. Appreciate it.
Those are off, yeah. Huh? No, we leave it out here. Yeah. That's my normal one here. No biggie. We'll get it. Next trip out.